Hey everyone, and welcome back to the Tinnitus Relief Podcast. My name is Ben Thompson, your host. Today I am here with a special guest, Chris Spankovich, who is an audiologist and PhD researcher. We're going to cover important topics like demystifying tinnitus, understanding the true root causes of the condition, and variations in sound therapy approaches, diet, nutrition, and so much more. First, I'd like to introduce Dr. Spankovich, who has extensive research in tinnitus as well as hearing loss, identifying different factors for what are the causes for tinnitus, what are the best solutions available. Dr. Spankovich is the author or co-author of over 20 articles in peer-reviewed scientific publications and 4 book chapters, and has given more than 40 presentations nationally. He is currently a professor at the University of Mississippi Medical Center School of Medicine and in the ENT department, and serves as the vice chair of research for the department, as well as the director of education in the division of audiology. Dr. Spankovich, welcome. And I'd like to first ask you to explain, why should we demystify tinnitus, and how does your approach help to really bring clarity to someone who's trying to figure this out?
Sure, Ben, and thank you for having me on. One of the critical first steps to the management of tinnitus is for the patient to have a clear understanding of why they are experiencing tinnitus. Why am I hearing this ringing, buzzing sound in my ear? Why am I hearing this heartbeat sound in my ear? Why am I hearing this clicking sound in my ear? And the causes of those different experiences of tinnitus can be very, very different. And understanding what the consequences of that cause are very critical then in regards to the reaction that the patient has, right? So a classic example of this is, say you're laying in bed and it's 3 o'clock in the morning and you hear a creak in the floor and someone messing around the kitchen and the fridge, and it wakes you up. Now, in one case, you could have family visiting, say your mom or your sister or cousins visiting, and you go, oh, that's just my mom. She couldn't sleep, so she's getting a glass of milk or something from the fridge. All right. In another case, though, you're home alone. There's no one else in the house. Now, in both those cases, the sound is the exact same. The creak in the floor, someone messing around the kitchen. The difference is whether that source is known and what is causing it, right? Because the known cause could have different implications for what the consequences of that sound. If it's just your mom or your family member, then the consequences are very minimal, so not a big deal. But if you don't know what the cause is, then that gets your brain into thinking, uh-oh, this could be a sign of danger, this could be someone here to hurt me, so on and so forth. So demystifying tinnitus and getting the patient to understand why they're experiencing tinnitus is very critical in the management of tinnitus.
When you explain this, it has to have the elements of what are the different root causes, what are the factors that contribute to why someone has it. And then, like you said, where is this going? What is my direction here? I need to have some element of control over this. Otherwise, I'm flooded with anxiety, stress, sleep problems, and tinnitus is front and center in my head. How do you approach your care? You still see patients. You're very close to the research in our community as well. Tell us more details about your approach and your perspectives here.
So the first step is very clearly a differential diagnosis, breaking it down in regards to when did the patient's tinnitus onset, what were the relative factors to the onset of that tinnitus, ruling in, ruling out different factors such as noise exposure, medications, ear disease, but considering all those different factors relative to the onset of their tinnitus, head, neck injury, other issues as well, right? All things that we want to consider. And then actually complete a comprehensive assessment of the patient to then correlate to those different potential factors that might be relative to the onset and perception of their tinnitus, as well as the reaction that they are having. So if you have a patient, and you're talking about primary tinnitus is the more common variant of tinnitus. Most patients describe as perceiving some type of ringing, buzzing, humming, variable type of sound. We're not talking about pulsatile tinnitus, like a heartbeat sound, or clicking tinnitus, which is commonly myoclonic activity. But ringing, buzzing, primary tinnitus, 9 times out of 10, a person's experiencing ringing, buzzing tinnitus because of reduced peripheral input into the auditory pathway. What is that most commonly? Exactly. What is that most commonly? That's hearing loss. right? That is the most common cause of tinnitus perception, is going to be that the sound getting up to the brain where we actually hear has been disrupted in some way. Now, there can be factors that create peripheral disruption. So, for example, a plug of wax in the ear, damage to the inner ear due to noise exposure, or there could be a central pathology, such as a tumor on the auditory nerve. The most common, though, is some type of disrupted input into that central pathway. Then we begin to look at some of these different factors. So, for example, an acoustic tumor, a vestibular schwannoma. These things always scare patients and going, this ringing could be a sign of a tumor. These things are extremely rare. We're talking about 0.00002% of the population has vestibular schwannomas. That is more than likely not the reason why you are experiencing tinnitus. The much more likely reason is that you have some evidence of reduced peripheral input, meaning some level of auditory damage related to likely hearing loss and likely sensorineural hearing loss, which is the more common type of hearing loss in adults, that has disrupted how sound is getting up to your brain. That disruption has created then a natural compensatory change the brain performs to try to compensate for the reduced amount of input. So if your brain's not getting the signal it was before, like your TV's not getting the signal like it was before because some of the wires have been frayed, well, your brain is going to change to try to compensate. Unfortunately, your TV doesn't have a brain to try to compensate for that reduced input, so you're just changing the contrast on the TV or trying to change the color on it to get it to improve the quality of the picture, but very limited in doing so. And the brain's limited in doing so in terms of compensating for hearing loss. It can turn up its gain, it can increase neural firing, and change its mapping around to try to compensate for that reduced input. But unfortunately, a very common side effect of those compensatory changes is creation of a neural static-like signal that is being sent to the auditory part of the brain, making it think a sound is there when a sound's not there. Tinnitus.
And are you saying that, number one, hearing changes, progressive hearing loss, loud noise exposure that leads to some hearing loss, even if it's mild, are you saying for most people who have tinnitus, that's the cause? And tell us a bit more about, between the ear and the brain, where does the tinnitus live in your understanding of the research, brain imaging studies, understanding of the anatomy? Where does tinnitus reside exactly?
Sure. So indeed, the most common causes of an acquired form of tinnitus are going to be related to sensorineural hearing loss. And the most common causes of sensorineural hearing loss are noise exposure, age-related changes, and then some level of drugs that have some ototoxic properties like cisplatin and aminoglycosides. So when these different factors cause a change in peripheral input, they end up resulting in these compensatory changes we were describing, but in a chronic way. Right? Because the input has been deprived in a chronic way. I know you're familiar with, and maybe even some of the listeners are familiar with, that there's been numerous studies that have been completed over the decades, placing young, healthy adults in sound-treated spaces or in an anechoic sound chamber, which is like the quietest, environment we can make in the world. And if you leave someone in one of those rooms for 5-10 minutes, 9 out of 10 or 8 out of 10 will start experiencing ringing, buzzing in the ear. The vast majority will experience tinnitus, right? Now, are we causing a pathology to these healthy young adults by putting them into this sound-treated space? Of course not. What we've done is put them into an artificial environment. And the brain, the auditory part of your brain, expects sound. The real world is not silent. Right? There's ambient sound around us at all time. But if that's disrupted in some way, even acutely, very briefly, the brain will begin to change to try to compensate for that brief change in what the input is. And so that's why these healthy young adults will experience tinnitus in a sound-treated space. Now, as soon as they come out of that room, their system's flooded with real sound again, so their tinnitus resolves. So what that tells us is that tinnitus itself is not a sign of danger. It is simply a sign that there's been disrupted input to the brain. All right. Where's that disruption at, and how that is, where is tinnitus actually happening in a pathway? Well, it's not happening necessarily in one place. right? So sensory neural hearing loss, for example, will involve damage to what we call hair cells. These are the sensory receptors of the inner ear. The primary damage tends to occur at the level of the outer hair cell. Another area where we see significant early evidence of damage is at the synapse. This is the place between the inner hair cell and the auditory nerve. That's in our world, we're recognizing synaptopathy, where there can be damage at the level of the outer hair cell and at the synapse. But that's why we call it sensory neural hearing loss, right? Because it's involving those two elements. So then along the brainstem and up to the brain, when there's tinnitus, we can see changes in activity as low as the cochlear nucleus. So the cochlear nucleus is the first level of the brainstem where the auditory nerve enters into the brain. And already at that low of a level, we can observe increase in neural firing, decrease in inhibition. So there's two major types of neurotransmitters, excitatory and inhibitory. Excitatory turn things on. This example is glutamate. Inhibitory turn things off, like glycine or GABA. Well, we start to see increases in glutamate and decreases in GABA and glycine, meaning that there's more excitation and less things that are turning things off when they're supposed to, right? Because the idea is to try to fill in the gap for the reduced input. So that's why many tinnitus patients will match the pitch of their tinnitus to a higher frequency, because that's most commonly where their hearing loss is at and where their brain is trying to fill in the gap. So we can see changes though at the level of the brainstem, all the way up to subcortical levels, all the way up to the auditory cortex itself, and beyond that as well. So tinnitus is not just a manifestation of changes in the physiology of the auditory pathway. It also involves non-auditory regions of the brain that are involved in our attention, that are involved in our memory, and that are involved in our emotional and stress-based responses. And that's why when a person is more stressed out, they're not getting sleep, they're having things going on in their life, more comorbidities, they have diabetes, they have heart, cardiovascular health issues. These individuals tend to have a stronger negative reaction to their tinnitus because these other portions of the pathway are ultimately driving the reaction to the tinnitus. The perception of the tinnitus we can relate to primarily the auditory pathway and at least the generation of that signal and its initial perception. Whether the person continues to perceive it and what their reaction is heavily dependent on non-auditory regions of the brain.
This is a short interruption from today's video to announce the tinnitus quiz. If you're watching this video, there's a good chance that you or someone you know has tinnitus. We know how much tinnitus can impact your daily life, and we're here to help. Visit tinnitusquiz.com and take a 2-minute quiz to receive personalized treatment plans that have helped hundreds of people learn to manage their tinnitus. Start now at tinnitusquiz.com.
Let's talk about the patients that you see, patients that come into your clinic and care you provide. Tell us about the kind of breakthroughs, realizations, insights, even therapies and treatments that help these individuals that you see when they're suffering the most over time and hopefully eventually getting much better. Tell us about what you see day to day in the clinic.
Well, I'll tell you, the primary first thing that I see with patients is them seeking answers. Often patients, by the time they come to see me, are a bit disillusioned. They have been told, don't worry, you'll learn to live with it. It's not a big deal. They feel like they've been dismissed and that their primary complaint has not been appropriately addressed. And in reality, it hasn't. Many times physicians and other healthcare providers will tell patients, don't worry, you'll learn to live with it. The truth is, there is some truth to that. The fact is that there is a natural process of the brain to habituate to things that it finds meaningless, right? And so this is a whole component and foundation to a lot of the approaches that we use in audiology for the management of tinnitus is to get the patient to habituate to the tinnitus. And habituation is indeed a natural process the brain can achieve on its own. But for individuals that are having challenges with their tinnitus, obviously it was not successful in doing so. So then we need to give them tools and methodologies to be able to engage that habituation process more effectively. And so what I do with patients is, one, I do a comprehensive assessment with them. I want to, again, demystify their tinnitus for them and get them down the right pathway. So if there is a medical pathology of concern, we're going to make sure that they're going down that pathway to have that further evaluation and management completed. For the vast majority, there's not a medical pathology at play. Again, for most individuals, it's hearing loss. So it's falling in the realm of audiological care. And then, of course, some patients are having a very severe emotional reaction. They may benefit from not only audiological care, but additional psychological or psychiatric care, depending on that patient's needs. Okay. And there's nothing wrong with that. Believe me, every one of us would benefit from a little cognitive behavioral therapy. It's, learning stress management techniques is good for all of us. But where I take the patient is first to demystify their tinnitus. Then we talk about the tinnitus is impacting them individually. How is this disrupting your quality of life? What are these individuals experiencing relative to negative thoughts and actions, or maladaptive thoughts and actions that they are displaying relative to the tinnitus? And let's address those. You can have, for example, a patient that loves to play music. Maybe they love to play guitar or piano, whatever it happens to be, or they love to go see live music at shows. But now they have tinnitus, and when they go to see live music shows, it just makes their tinnitus worse, and they go into a bad place. And so now they stopped going to live music shows, right? Well, we could talk to the patient about this, like, well, listen, let's find a way for you to re-engage in that activity, because that's you not going to live music shows is just reinforcing that the tinnitus is something negative. So let's talk about musician earplugs. Let's talk about some earplugs that are going to provide protection, that are going to limit you experiencing a spike in your tinnitus and allow you to still enjoy those venues and that experience while protecting your ears and not exacerbating your tinnitus, right?
I want to ask a follow-up question. So demystifying is so important, because that helps retrain the brain to promote this reduction of tinnitus, to promote habituation. That's why we do it. Everything we do, everything that we encourage here on our YouTube channel, etc., is promoting the brain's natural process to reduce tinnitus. That is the goal. We're all on the same team there. What are the common misconceptions patients have when they arrive in your clinic, when they have conversations with you? What false beliefs do they have? What false information have they consumed? What are those common threads that I think a lot of our listeners will get value from?
Sure. So some common threads with that is that because of this tinnitus, I can't hear very well. So that is a very, very common misinterpretation of the patient that makes sense, right? You have ringing, buzzing in your ears. Your first reaction is not, oh, this is good. This must mean that I'm developing super hearing, right? You have ringing, buzzing in your ear. You obviously think something's wrong with my hearing. I didn't have this before. This is abnormal. So first of all, understand that tinnitus does not actually cover up your ability to hear. It can be distracting. It can be annoying. It can have some influence on speech and noise understanding. There has been some data to support that, but this itself does not cover up your ability to hear. That's not why you're having difficulty understanding your spouse or your grandchildren, or communicating in crowded environments or cocktail party type of environment. That's your hearing loss. And luckily, we have a lot of resources to help with hearing loss, whether it is communication strategies, to over-the-counter, to prescription-based hearing aids, to cochlear implants, right? To BAHAs and bone-anchored implantable devices. There's all different types of options to help manage your hearing loss, depending on your hearing loss and the severity. The tinnitus, though, is not covering up your ability to hear. Tinnitus does not necessarily get worse with time. Actually, for individuals, tinnitus tends to get better with time. Now, the tinnitus signal itself may change. This doesn't mean that your brain cannot rehabituate to that signal, right? So for example, you put shoes on your feet every day. You don't necessarily wear the same shoes. Okay, you might put boots on one day, sandals on the next day, sneakers on the following day. Your brain habituates to that new pair of shoes every time that you put them on, right? Your brain can accomplish the same thing, even if the tinnitus changes in its quality. If it gets a little bit louder, changes in pitch a little bit. Some of these things can be related to sort of a person experiencing some hearing loss as they get older, which may re-engage their attention to their tinnitus. But your brain can re-habituate to these events again. If it's done it once before, it can do it again. And once you do achieve habituation, your brain can now apply that to the future as well.
What we've learned so far is that these common experiences, which are very challenging which are overwhelming, and the feeling of being dismissed by another doctor, those experiences are validated here. And we're building this case of retraining the brain and showing a different perspective on how to sort tinnitus neatly, despite it being annoying, challenging, loud at times. When we can settle the mind, settle even the body's reaction as well to tinnitus, the brain has an easier time to reduce it naturally through this brain system called habituation. And let's talk more about solutions, next steps. Number one, do you use sound as a therapeutic tool? Do you use sound therapy with your patients as an audiologist? And then if you could summarize your understanding of the sound therapy research and how you and your colleagues use sound therapy, I'd love to hear your perspective on that, Chris.
Sure. So there's two things to enable patients to help control their tinnitus. And indeed, yes, you can control your tinnitus. It is possible to control tinnitus. The two things that help patients control their tinnitus are one, sound, and the second thing is attention, okay? If you have sound on, most individuals with tinnitus, not every person with tinnitus, but most individuals with tinnitus, they can turn up sound and suppress the perception of their tinnitus, whether that's music, whether that's a white noise. For some patients, simply putting a hearing aid on their ears suppresses their perception of their tinnitus without even using an additional sound therapy type of sound. The second thing, attention, of course, is very critical as well, but we'll get to that next. So with sound therapy, I indeed do use sound therapy in my practice, and my recommendations can vary depending on the patient's needs. Often we'll start with very simple strategy of using a sound that they find relaxing and soothing, a sound therapy sound, but not that they're actively listening to. Okay, so not their favorite music, not their favorite podcast, Treble here. They can listen to those other things. They can listen to music and podcasts and things of that nature. But this sound, I want to be a passive sound, but I want it to have a relaxing, soothing qualities. So many patients will choose water-based sounds like ocean or rain or waterfall. Others like white noise. Other like crickets. And it all depends on individuals. It's a subjective thing. So they identify this sound therapy sound, and then I want them to use that in a very strategic way to set at a level where it begins to suppress the perception of their tinnitus, not completely mask it or cover it up, but begins to suppress the perception of the tinnitus and provide some relief. And then I want them to keep that sound around as much of the day and night as possible, okay? During the day, now we get into variations of how we can approach tinnitus. They can use everything from wireless earbuds to hearing aids. If the person has hearing loss in addition, that's complaints of hearing difficulty, then hearing aids would be the path I would recommend going, okay? Because now we can treat your hearing loss and help you manage the tinnitus simultaneously through amplification, right? If they don't have any perceived hearing issues or don't want hearing aids, then we can talk about other ear level devices, which can range from ear level sound generators to just simply wireless earbuds, right? One of the critical elements, if they are going to use something like a wireless earbud, is I like the patient to have an earbud that provides transparency so that they can hear the world around them and they're not self-isolating themselves, okay? Then at night, I recommend continuing to have sound in the evening as well, and that can be achieved through something like a sound pillow or a dream pad or even a tabletop sound generator, depends on the patient. The idea is I want you to have this sound therapy sound around as much of the day and night as possible, 24/7 if possible. You can't turn off your tinnitus. I'd prefer you not to turn off this sound. And the idea is that your brain will eventually habituate to the sound therapy sound, just like it does with other environmental sounds like the air conditioning. Right? Air conditioning cuts on, you'll spend the next 45 minutes listening to your air conditioning. Go back to doing what you're doing. You don't notice the air conditioning again until it turns off. So I want your brain to treat this sound sort of like the air conditioning instead of put it to the background. Since it's basically suppressing the tinnitus at this point, then it's pretty much going to take the tinnitus to the background as well. And then slowly over time, we adjust that level of sound therapy to train the brain to use just ambient environmental sound as its suppression factor and get to the place where the person is habituated to their tinnitus, so having less reaction and noticing it less and less and less.
Yeah, I find that sound therapy, there's one material tool that's going to help someone get through the toughest times of tinnitus and live a full and productive life. It is having targeted use of sounds to help their brain get over tinnitus, move through it, and be in a place where we no longer need the sound therapy to live that full and productive life. That's another common misconception patients have that I find is if I use devices on my ears for tinnitus, like sound generators, tinnitus maskers, if I use sound therapy, it's a crutch and I'll need it forever. It's actually not true. I find it similar to a knee rehabilitation where we use a knee brace to get us through the rehabilitation process. And at the end of it, we may not be back to 100%, playing soccer, playing football with our kids going strong, but we can be in the game. And similarly, the tinnitus is not going to zero in most cases, but it's going to be much better managed after the rehabilitation.
That's a strategic element as well, where what I commonly have patients do is turn down the level of sound therapy as they are achieving habituation. So while the sound therapy is on the full volume, while you're wearing it, you don't really hear your tinnitus. When you're ready for the next step. Next step is to turn the sound therapy down one notch and then habituate at that level. And then once you're habituated at that level, turn down one more notch. And then once you're habituated at that level, turn down one more notch. It's like tapering the brain off the tinnitus. And that then provides a goal for the patient that they don't necessarily need to use that sound therapy sound for the rest of their life. Now, if they're using hearing aids, probably they're going to be using the hearing aids because the hearing aids are helping them hear as well. But still, they don't necessarily have to have this constant masking or suppressing sound around you once you reach a habituation place. It doesn't mean you won't need it sometimes. Sometimes you might need still to, put that sound around just to give you some relief. I've had tinnitus for 35 years now, 34 years. I lost a hearing in my right ear when I was 14. So I experienced a sudden idiopathic hearing loss. And my tinnitus is 24/7, sounds like a fluorescent light bulb going on, type of sound. I can listen to my tinnitus and hear it anytime 24/7. I just don't do that anymore because I've luckily been able to achieve a level of habituation. And I'm so habituated that most of the time I don't hear tinnitus at all. It's like it's not there. However, when I'm talking about tinnitus, like right now, my tinnitus is off the chain. If I've had a stressful long day, sometimes I'll lock in on it and go, why do I do that? Why did I do that? And I do that as well. But I employ these same strategies. I put on some sound and then I go distract myself and it falls back to the background. And that's ultimately the goal, is to get to a place where the tinnitus, though it may be there, it's not impacting your day-to-day function.
Well, we've covered the two things that will help you control tinnitus today: your attention and using sound via sound therapy. We're here today with Dr. Chris Spankovich, audiologist and PhD researcher. If you found this helpful so far, please comment below here on YouTube, helpful. And Dr. Spankovich, the last question here is for you. Trends in tinnitus research, trends in different options of how the best professionals are approaching tinnitus care. And what are you hoping to see here in the next 5 to 10 years of how we can take better care of individuals who are struggling with tinnitus?
So, the best thing to help with tinnitus is evidence-based research. And there is a lack of evidence-based research in the realm of tinnitus. Tinnitus is not cancer. The money to sort of do research in tinnitus is not as strong as it is for some of these other disorders and chronic diseases. That being said, there are areas that we are observing some good work being done. Some of the first studies have just happened in the past 10 years or so that have really looked at things like tinnitus retraining therapy, tinnitus activities treatment, cognitive behavioral therapy-based approaches to tinnitus management, and compare those to other types of approaches, right? Looking at hearing aids versus sound generators alone versus just counseling. All of these different things can be potentially effective and help patients diminish the perception and reaction to their tinnitus. But ultimately, one of those things will probably be better for one patient versus another. And that's what some of this research does not capture because it's comparing groups to groups, not individuals. Where we're seeing some increase in literature is using things like bimodal stimulation. And this is where we'll use some type of electrical stimulation of the somatosensory pathway paired with a sound. And the idea behind this is not for habituation. The idea behind this is to try to retrain the brain to basically get rid of the tinnitus perception or alter it in a way neurologically that the signal's not as robust. And right now we're sort of in the early phases of that work, and most of the studies I've looked at some bimodal stimulation at this point. There's no evidence it's really stronger than just using sound therapy. It's not curing tinnitus or anything at this point. So there's limitations there. But then there's some groups that are doing deep brain stimulation where there's neurological implants that are seeing some success with that as well. But then, you're talking about a very, very serious surgery for something that itself does not really have any comorbidity or mortality associated with it, right? Morbidity or mortality. Tinnitus itself can't hurt or kill you, though your reaction to it can be something that is highly significant. So there's deep brain stimulation work that's ongoing. One area that we're looking to expand upon is other types of neural stimulation, such as cochlear implants. As you're familiar with, many patients that end up getting cochlear implants because they have severe to profound hearing loss, but also have tinnitus, while the implant is on, it can suppress the perception of their tinnitus. So there's some groups now looking at using neural implants either to near the cochlea or in the cochlea itself that aren't actually helping with hearing, but simply are providing a neural stimulation to suppress the tinnitus perception. But more than likely, that's not curing the tinnitus because you take the implant off, the person has tinnitus again. Rather, it's suppressing it similar to how sound therapy suppresses. In terms of drugs and finding a pharmaceutical that is going to shut off tinnitus, it's probably not going to happen in my lifetime. There may be some things for specific individuals that ends up working out for them, but finding a drug that cures tinnitus has a lot of limitations in effectively doing so, because you're talking about targeting major neurotransmitters that have ultimately effects across the brain, not just in creating tinnitus perception. So I think the big thing out there right now is some of these neural stimulations and what the future they may hold in helping to suppress tinnitus perception. I think, a lot of work in moving and getting therapeutic counseling-based opportunities online, available through smart devices, is going to expand resources to patients, which I think is a big thing. Again, these things aren't going to cure tinnitus, but they're going to help people habituate to tinnitus. And now having a method to do so, and having someone who's knowledgeable at the other end of that app or that Zoom-based conversation is going to mean a world of difference if you don't have someone in your local community, right? A huge thing that helps with tinnitus in terms of counseling, habituation, there's a very large clinician effect. If the clinician knows what they're talking about and they have a lot of experience in working with tinnitus patients, the tinnitus patient is going to trust them more, and their response to actually doing the steps that they're supposed to do and the encouragement to do so, it's going to be even stronger. And they're going to have a better experience with their habituation process. So those are some of the things that I see as areas where I think there's going to be some growth, a lot of in the neural stimulation area, though.
Yeah. Well, we hope to have you on again to the Tinnitus Relief Podcast here by Treble Health to follow up on these important topics. I can personally say I'm grateful you're dedicating your work to those who have tinnitus. It means a lot to me. It means a lot to thousands of others. I'll give you the final word here. What is your message of hope and encouragement for someone who's living with tinnitus today?
Sure. My message is that, so the brain can habituate to almost anything. Have you ever seen the show Hoarders, where you'll have people that hoard things in the house and they go in there and they clean it up and everything? Well, the people that hoard animals like cats, they'll have 150 cats in their house. And when the people go in there to clean it out, they have to wear hazmat suits, right? To clean that out, because the smell and just it's just too strong. There's a family of 4 living in that house that doesn't smell a thing, right? You can habituate to almost anything. If you can habituate to poison, you can habituate to your tinnitus. There are really 5 things to this process. 1, understanding what it is, understanding what your tinnitus is from, why you're experiencing. Number 2, realizing, yes, your brain can habituate to almost anything. 3, we can use sound. We can use attention-based exercise to help mitigate the reaction that you're having to the tinnitus. And finally, eating healthy, exercise, good sleep. Though these things are not going to cure your tinnitus, they can help alleviate stress, improve your overall physical well-being, which can improve your mental well-being, which will improve the reaction that you have to your tinnitus. It's not one thing. It's a combination of all of those things that can help lead the brain to habituation process. And your brain can do this if you start implementing these strategies.
Thank you, Chris, and thank you all for listening. We'll see you on the next episode. Bye-bye.